Thank you very much. It makes me think, for those of you that are Monty Python fans, the saying, and now for something completely different. So I have no financial disclosures. I just have one regular disclosure, and that's my nurse practitioner, Elizabeth Kelly, Beth Kelly, helped me prepare this talk, and I want to give thanks to her for helping me with this. So Dr. Fuqua at the beginning talked about what a nice day it was. 50 years ago to the week, this was Chicago, the worst snowstorm that we've ever had here. So it definitely is a nice day today. So San Antonio, while it's the largest single organ cancer conference in the world, it's not really one for local therapy. But that doesn't mean that there's not some good things sometimes that get presented. This was not one of those years. But I do have 5 research-based studies and then 3 special lectures that we'll talk about that are really review lectures. I won't spend a whole lot of time on those. But there's over 100 posters, and maybe I figured we could go through each one of those individually just to... So these are the topics I'm going to cover. For those of you that want to look into this more, I highlighted the numbers here so that you can quickly find them in the program. I think our slides are available, so if you want to go back and reference this, this is how you can do it. All right, so the first one was truly a surgical talk, but I think it has broader implications than that. And this was using a radioactive seed to localize a breast lesion rather than the wire localization that we currently do as surgeons. Why even consider this? Well, for those of you that do this, and I know that there's a few surgeons in the audience, it's not ideal. There are patient delays. It can't be done the day before. There's a wire sticking out. Patients don't tend to like having this done. And honestly, there are technical difficulties with the axilla, and I think that while this study didn't address that, this is probably the best utility of this in the long run. It does use a radioactive I-125 seed, and the benefit of that is that the gamma probes that we use in the operating room now to identify sentinel nodes are for technetium, but there's actually a switch on the back, so you can switch it to identify radioactive iodine, so it is something that probably could be easily adapted to most institutions. And again, this study only looked at breast lesions. Very briefly, what the study showed is that it's comparable to wire localization in terms of what sort of specimen is obtained. And so since it's comparable, the real benefit is that this can be done the day prior, so patients can then have their surgery at 7:30 in the morning, because we know that the radiologists don't get there at 7:30 to even start putting the wire in, that there's no wire sticking out, so there are patient benefits. And then honestly, while it wasn't addressed in this, I think that it can help localize nodes, which will become more evident as we talk later here. All right, acupuncture. Honestly, you'd think, why am I talking about acupuncture, right? But I found this study very interesting. It wasn't just a poster, it was a true poster discussion. And as you see, it came out of the Dana-Farber Cancer Institute, so there is some backing behind this. What is acupuncture? I think most people realize what it is, but just in case, it's where needles really are stuck into the skin. They are sterile needles. I actually did a lot of research into this to figure this out because it seemed intriguing to me. But they're put in certain spots, so certain locations or what's called meridians. And by doing this, it's supposed to alter the flow of energy in the body. And there is a lot of data out there about this. Actually, I first became intrigued with this when about 20 years ago, I had just started practice, and I was asked to give a talk in Vietnam, and while I was there, they had me operate, which was an interesting experience in and of itself. But I went to do a laparoscopic procedure, and the patient already had the laparoscope in her belly when I walked in, and she wasn't asleep, which to me was just shocking. She had an IV with who knows what going through it, and all these needles sticking out of her head. But that was enough to keep her under anesthesia. So clearly there is something to this. For those of you that give chemotherapy, you know that there is data out there to suggest that this does help with chemotherapy-induced nausea and vomiting. I don't know if it's scientific data, but there is data out there. And honestly, as I looked into this, there are multiple reports about using this technique, acupuncture, for chemotherapy-induced peripheral neuropathy. But this was really the first true scientific study that I could find that showed honest relief in a randomized fashion in patients. And they used a number of pain indices and peripheral neuropathy indices that have been validated and showed a real benefit. So we're fortunate enough at Loyola to have an acupuncture program. I don't know if we've used it for this yet, but I have used it for some of my post-mastectomy pain patients. And I think that honestly, of all the studies, this one may make the most impact, which is kind of crazy. All right, another one of the research studies was about a DCIS predictive score. There are lots of them out there. This was actually presented by Pat Whitworth from the Nashville Breast Center. This looked at a population in the Kaiser Permanente system in the northwest part of the country. It's clear more and more that we probably are over-treating DCIS. The problem is, how do you find out, or how do you predict which ones are the patients that don't need extra treatment? So one of our sponsors for this meeting, Genomic Health, has an assay out there. This is another one of those assays to help try and figure that out. It looked at 3 cohorts from the University of California, San Francisco, Uppsala, University in Sweden, and the University of Massachusetts. They looked at a number of biomarkers. Wasn't really quantified exactly how that was done. They did look at some clinical features as well. A little sketchy on some of the data, or some of the details for that. What they found is honestly kind of what we already knew, that if you are low risk, that the risk of recurrence without radiation is similar to the risk of recurrence with radiation. But if you are high risk, radiation really should be added. So not anything groundbreaking, but just more validation of the fact that there probably, or not probably, but there are a subset of patients with DCIS that can benefit from not having radiation. So Susan Komen Foundation is a big sponsor of this meeting, and they provide a couple awards every year. One of them is in basic science, and one of them is for clinical research. This year's award was given to Dr. Monica Morrow, who is a well-known breast cancer surgeon and the chief of the breast service at Memorial Sloan Kettering. She kind of gave an overview about local therapy, which I've kind of put into 2 spots. So the first thing she talked about was lymph node therapy. And I think everyone knows this, but just why are we so concerned with not doing axillary dissections? Honestly, my residents like to do it. I think it's a fun surgery. I get paid more to do that than doing a sentinel node biopsy. But there are real risks to doing an axillary dissection, as listed here. And hopefully you haven't seen this, but this is a patient that I took care of many years ago, and this was a life-limiting thing for her, having this significant lymphedema. So one of the things that Dr. Morrow talked about was an update of the Z11 trial. And just to refresh your memory, Z11 looked at people with somewhat favorable profile breast tumors that had 1 to 2 positive sentinel nodes, and that there was no difference whether they had an axillary dissection or had no axillary dissection, and that the overall survival and disease-free survival was no different in those patients. She presented data that suggested that's already been out there, that now longer-term follow-up of these patients shows that there is still no difference. And again, this applies to better risk patients, and that in this extra 5 years of time, there's only been 1 additional patient that's recurred in the lymph node basin. So pretty encouraging results. But what about those higher risk patients, patients with larger tumors? triple-negative breast cancer patients. She did talk about ongoing studies, both at Sloan Kettering and at other places, that they are looking at trying to expand the indications. So while you may argue that Z11 wasn't a great trial, some of these others probably are even worse because they're not as big and they're more single institution. But there is data to suggest, because of the addition of adjuvant therapy and radiation therapy, which most likely affects local control, that we probably don't have to do as many axillary dissections as we are. So local therapy for the breast. What's interesting is that when I first started doing breast surgery 20 years ago, we followed the NSABP guidelines that said, and I worked with Janet Walter at Rush, who was a big NSABP person, and if the tumor didn't hit the ink, you were fine. There was no reason to do more. Somewhere in the last 20 years, that changed. And as you know, there have been lots of people that have talked about different margins. It had to be 2 millimeters for invasive. It should be 5 millimeters for DCIS, and all sorts of combinations in between. This created such a controversy that a multidisciplinary group of people, so surgeons, surgical oncologists, radiation oncologists, medical oncologists, got together and published a set of guidelines in 2014 that kind of went back to where it was before. And at least for invasive cancer, that if the tumor was not on ink, that margin was considered fine, and that there was no reason to go back and re-excise those patients. So a 1.5, as the question, a 1.5 millimeter margin does not have to be re-excised in invasive cancer. So one of the other studies, research studies that was out there is the Guinea-2 trial from France. This is similar to the Sentina and the ACASAG trials, looking at sentinel node detection after neoadjuvant chemotherapy. Unfortunately, not a whole lot new was added from this, but what this trial looked at was, again, in people that had a positive node, and they call it pathologic, but honestly, these patients had an axillary ultrasound pre-chemotherapy. If it was negative, there was no biopsy done of the lymph node. So that's not really pathologic, but that's how they listed in their study. But for those that looked suspicious, they had confirmation with a fine needle aspiration. For those that were considered positive prior to neoadjuvant chemotherapy, all of those patients got sentinel node, or the majority, the plan was, and an axillary dissection. And for those patients that had a negative node pre-chemotherapy, they had a sentinel node biopsy and plus minus axillary dissection based on the results of that intraoperative value. So this is the group of patients that had a positive node prior to chemotherapy. The thing that kind of stands out to me is this 80% success rate in finding a node. So that means 20% of the time they were not able to identify the sentinel node. And that's a lot lower than what we see in some of the other studies that have been published. Nevertheless, even in that group, if the sentinel node was negative at the time of surgery, they found that the false negative rate was 12%. And the data varies from 10.7% to 20%, but anything greater than 10% is considered unacceptable. So this just pretty much validates what is out there in the literature. What's interesting is one of their conclusions was that if the node was negative prior to chemotherapy and it was still negative after chemotherapy, some of those patients actually got sentinel node, or got an axillary dissection, and that was based on surgeon preference. But when I calculate this data, when you look at this, so these would be false negative patients. But this false negative rate is 20-some%. So it kind of goes along with what is out there as a general false negative rate. But what's important is that there's no difference in survival. So those patients do just as well. So even though they had a negative sentinel node you figure that some of those other patients that didn't go on to axillary dissection, they don't do worse. There are clearly other factors that are involved, and so maybe this false negative rate of 10% isn't as important. No one knows the answer to that yet, though. But their conclusions were that if the node is positive prior to neoadjuvant therapy, that all those patients, even if they've had a good response, need to have an axillary dissection, that if it's negative prior to chemo and the sentinel node is negative, that they do not have to have an axillary dissection. There were two somewhat review sessions. One was given by a surgeon, Dr. King, and talked about surgical considerations after neoadjuvant chemo. So some of that we've kind of already discussed, so I will highlight this quickly. But in essence, what she talked about was that with the increased use of neoadjuvant therapy, we need something better than surgery to figure out what's going on. So our current radiologic means are not ideal. That if you do see complete shrinkage of the tumor on preoperative imaging, that you don't have to go back and remove that entire area where the tumor was before. So you can do something smaller than that. With the caveat that if that lumpectomy specimen that you obtain shows widely scattered positive cells, that you should honestly consider going back and taking more, because we always think of tumors as shrinking in a uniform fashion, and if it was 5 centimeters and shrunk down to 2, and we remove 4 and everything's fine, it should be okay. But some of these tumors don't shrink like that. They haven't read the book, right? So they're just shrunk in individual spots. And so if you see a tumor after a lumpectomy that has multiple scattered positive foci, you probably should go back and take more. She also addressed in her talk, again, what I just talked about, what to do with the node that's positive that converts to negative after chemotherapy. But she came up with kind of some of the things that we need to talk about and some of the issues that need to be addressed that are being addressed in some newer studies that are either ongoing or proposed. And that's that while I take dual agent for granted, so I use both a radioactive agent and a blue dye, not everybody does that. And we know that the success rate for doing that is much higher than the 80% that they saw in the study that I talked about. A lot of these patients in the ACOSOC study used preoperative axillary ultrasound to examine lymph nodes, but that data was never published. We don't know how that kind of panned out afterwards. And so we need to find some better way radiologically or some other way to figure out which of those patients have a better response. You need to remove 3 or more nodes. Now, she talked about that, but as Dr. Albay knows, there was a lively discussion amongst a bunch of surgeons at the iSPY meeting mandating that so many nodes be removed. But for those of the surgeons in the audience, you know that sometimes you only find one lymph node. And it's not like you can go searching for other lymph nodes and think that it's the sentinel node. I mean, so mandating 3, yes, it would be ideal if we could get more to sample them. It's just not always possible. There's talk about, so we've gone back and forth about immunohistochemical positive nodes and how we shouldn't consider them in overall prognosis. But maybe in this subset of patients that have had neoadjuvant chemotherapy, it might be something that we look at, and if they have still IHC positive nodes, that those nodes should be considered positive and an axillary dissection should be performed. But I think the most important thing, and something that it surprises me that it hasn't been done yet in these studies, is that, so we have a tendency to leave clips in the nodes when we biopsy them at Loyola, but not every place does that. More importantly, even if it is done, those nodes aren't always removed at the time of sentinel node biopsy. And what is the literature out there shows that 20% of the time, that clipped node, which we know is positive, isn't the sentinel node. So in these studies that didn't mandate that that be removed, it's possible that, yes, we're removing the sentinel nodes, but we were actually leaving the positive node behind. And so I think in the new studies, that's something that has to be done. Another educational session, review session, talked about the implications of radiation after neoadjuvant therapy. and he looked at a bunch of studies, Dr. Smith from the Anderson Cancer Center. The bottom line is that he presented a long talk, and the conclusion was that there's no clear consensus, especially in those patients that have had a pathologic complete response. We actually talked about this at our breast conference yesterday, where we asked Dr. Small, our chief of radiation oncology, what we should do, and he said, well, if we knew what to do, we wouldn't be doing all these studies now, because there is no clear consensus. But in essence, what he said from his talk is that this new ongoing study, B51, is looking at the specific issue about what to do in the patient that has now pathologic complete response in the axilla, and randomizing those patients to either getting post-mastectomy or nodal radiation in the case of breast conservation surgery versus no radiation. He also said, and I think most people kind of agree with this, is that if there is still significant disease after chemotherapy, that those patients probably should get some sort of additional radiation. So finally, something that I was very much looking forward to this talk, and it disappointed me. And that's what to do with the patient that receives radiation post-mastectomy, post-reconstruction. It's a topic that we go back and forth with our plastic surgery colleagues, with our radiation colleagues, and there's no clear consensus. And I was hoping that this talk would solve that. It didn't. So it is a prospective study, but it's not randomized. It was multi-center, so that's good. But it looked at complications from radiation and patient satisfaction. The problem was, and this came out in the discussion, when somebody asked them, well, when did this person have this? They don't have any idea when that was. So we don't know when things were done and the timing of them. So it really limits the conclusions. What we do know is that there were a fair number of patients that received post-mastectomy, post-reconstruction radiation. And when you look at it, and this is data that's really kind of already known, is that those people that are radiated do worse than those people that aren't. And so that's not earth-shattering, but that's the data they presented. No one wants to see this, right? I mean, this is a lady that had an immediate implant placed and then developed this. You can see the mesh underneath there. This is a lady that had a complication of her implant and then had to have a tram flap put in. And so this is an autologous reconstruction, so using the own tissue to do this reconstruction. The problem with this study is that while they talk about autologous being better, we don't know if they're applying that data to just this person that had a failed implant and then had autologous, or whether autologous was done before the radiation. And so that's what really makes it hard to interpret the data from this study. Other things they talked about is that there was a high % of failure, and the worst group was those people that had implants placed and radiation afterwards. And that failure rate is 18.7%, but it's not 50%. And so that's something to think about. Because what do you do with the patient that's not a candidate for autologous reconstruction? For whatever reason, you can't do a tram flap on her, or she has already had an injury to her latissimus and you can't use a latissimus. So I think it's still something that needs to be considered. Again, I wish that this study would have addressed it, but it really didn't. The conclusion from this study is that autologous reconstruction without radiation had the highest satisfaction scores. I think everyone kind of already knew that. That autologous reconstruction with radiation, again, whether it was done before or after, we don't know. And implant reconstruction without radiation were equivalent. And the lowest category in satisfaction and whatever is the people that had radiation and an implant. So I tried to summarize all these talks into one neat thing, and it was a little hard, but I think I got it all in this. And that's that local therapy is clearly changing, especially with the increased use of neoadjuvant therapy. And as surgeons and as radiation doctors, we are meeting this change and coming up with studies to help address this. However, we need a better way to evaluate what the post-neoadjuvant therapy patient looks like. Who gets a complete response, whether that's by better imaging or less invasive surgery. We need something better, and we need to work on that. And we just need to keep in mind that patients are surviving. They're surviving with breast cancer because you guys as medical oncologists are doing a great job. But we as local therapy people can't do something bad to them so that they end up like that lady with the bad lymphedema.